Yeah. Good morning, everybody. I am Dr. Ashutosh Kumar. I am a electrophysiologist come heart failure specialist working in Kamineni Hospital. And today we are here to discuss one of the important condition of the heart disease, which is the end of most of the heart diseases, what we call as a heart failure. And this word is like a bombardment. If somebody has been diagnosed means heart and that is failed. But before going in discussion, I will try to impress what exactly heart failure is. So, if you have been diagnosed with heart failure, nothing to worry. No doubt the disease has gone to the next stage, and heart failure means not the heart has failed, heart is impaired or its efficiency is reduced. So, it is the impairment of its full efficiency by which most of the persons are living on this world. So if you are having normal heart, you will be able to do whatever activity you want. You can scale up, you can scale down depending upon your situation. So if you have to climb a mountain, slowly you can, or with exercise or with your uh, training, you can do it. But when you are diagnosed with heart failure, those efficiency will not be so easy, or you will be having a loss of the particular efficiency which is needed to climb the particular mountain, or if you can say the particular job. So the strenuous activity, depending upon how much heart compromise is there, we can say you are having a particular heart failure type. We are having four variants, or we can say, not to say variant, the stages of heart failure. Stage A, B, C, and D. So stage A means you are having risk factor. Stage B means you are already having some changes. Stage C means there is heart failure has already started becoming symptomatic, and stage D means it is refractory heart failure. So like that, this is what you call classification or stages of the heart disease, and each stage is of, having their own way to diagnose by either by the clinical evaluation or by the echo or other added investigations. But the compromise can be mild to severe. If a person is not able to do day-to-day activity, or he is getting breathless while going in washroom and coming back, means his cardiac impairment is of severe type, means he is not able to do his day-to-day, and we give as a class 4 grading, means the person is not able to do, and it may be transient, it may be a permanent type of means the patient has reached to that he is not able to do. Sometimes the illness will come in form of infection or any metabolic abnormality, and the person who was doing well with the same impairment of heart function, but it is acute deterioration, means all of a sudden the pumping has reduced over time, and patient is not able to do the activity which he was able to do earlier with some difficulty. So this acute drop we call as a acute on chronic heart failure, means already the heart function is impaired, but due to the acute insult, the person functional deterioration has been markedly increased. So in that situation, sometimes the one of the important parameter of heart failure we use as echocardiography. So echocardiography, we will be having some parameters on which we diagnose, okay, your heart pumping is around 40%, 35%, or 60%. So 60% is the 55 to 60% is the normal heart pumping, what we call the left ventricular ejection fraction. And when it is falling below that, then we can say that your functional capacity is reducing, and when it is below 35, means LVEF, left ventricular ejection fraction, is less than 35%, we say that you are having a severe compromise of the heart function. But this is one of the subset of the evaluation. There are other, like a diastolic component, your chamber size, the particular type of disease you are having, coronary artery disease. There is also coronary blocks, which after that the your heart pumping is reduced, or it is a valvular compromise, means your valve is leaking, or it may be some congenital heart disease, or you have undergone some sort of surgery. So these are different relaxation. In our medical terminology, we call is systole, means contraction, diastole means relaxation. So If your heart function is compromised on the contraction part, we call as a heart failure with comorbidity. Means if the patient is not having well controlled diabetes, control it. If the patient is having respiratory problem, control it. If patient is having renal compromise, control it by the medical mean or by the intervention point of view. So the heart failure with preserved ejection fraction, when the pumping is good, it is comorbidity which we target and treat the patient. But coming to the patient in which the heart pumping is rich in salt, pickles which are rich in salt, they should be taken off from your meal. So you take all the meals, provided this should not be there. Vegetarian versus non-vegetarian, people are a bit confused, but I will suggest be in moderation. Better to avoid the non-vegetarian if possible. If at all you want to take, go for the fish. And vegetarian, if you can, whatever the food you are able to take. Mental trauma to the patient and the family that now heart is failed, so we should not do any activity, otherwise it will fail further. So let me impress this point. Heart is a structure, we have not to stress it, but for its functional improvement or maintaining its normal function, day-to-day activity has to be done to make it better over time. I am coming again on this point. If you are using your heart and you are not stressing it, then you are doing a service to the heart, or we can say one pill is called exercise pill. Means exercise is something which helps heart to rejuvenate. So if you are doing walking also, or if you are going for cycling also without straining yourself, because when you have been diagnosed with heart failure, you may be deconditioned, means you are not able to, you are not going out, or you have been functional compromise has happened due to the mental trauma. For few days you are not able to walk. The next day, the time you start walking, you feel more exhausted, sometimes breathlessness. It is normal, because you have stopped your day-to-day activity, and at the same time you are having the fear factor. So take out those fear factor and take the challenge that yes, with the same disease I am going to stay, I am going to do what I was doing, and I will take the support of the medical system or medicines to do better over time. So this attitude is very essential when you have been diagnosed with heart failure. Death and complications are the part of this illness, any illness, and that nobody can predict, and we should not predict also. We have to do the best from our end and leave the rest of the things. What are the things we have to discuss with the doctor? What are the things you are facing while doing day-to-day activity? So exercise nourishes your heart, it rejuvenates the heart, but you have not to stress. Means you have to first walk, and over the time, whatever the walking distance, you have to improve. So exercise is a pill, and heart failure patients should try, but not in the exhausted fluid overload condition. Means already you are having pedal edema, means swelling of the feet, you are not able to sleep in the night, you are sitting in the night. That is not the, when you have come out of your acute crisis, or you can say acute stage, then you have to start this one. And over the time, maybe the cardiac rehabilitation team will give you the advice how to go forward, and what are the things do and don'ts regarding the exercise point of view. So exercise, diet, I think most of the things I have tried to touch on those points. If you are having any questions and queries, certainly I will try to address you also. Now coming to the second tier of treatment, this is the foundation, means diet, exercises for any illnesses, we have to go by that one. But the second part is the medical treatment, intervention treatment, and surgical treatments. So first tier of treatment is medicines, and medicine is lifelong, because your disease is also lifelong. So heart pumping has been weak. We are having some medicines which over the time improves or that supports your cardiac system. So the same work it is able to do with less stress or no stress, like that. So there are medicines, there are 4 categories of medicines. One we call as a beta blocker, second we call as AC inhibitors, third we call as diuretics, and fourth there are new medicines as also called what we call as SGLT2 inhibitors. So different class of medicines are there, what you tolerate well and your doctor will suggest you. And this is particularly we are having a lot of options when the patient has been diagnosed with heart failure with preserved ejection fraction, with reduced ejection fraction, means your ejection fraction or heart pumping is low. In that situation, the medicines, we are having more medical options, means we can give a lot of medicines and try which is suiting you and on which you are doing fine. That is one part. Coming to the second part, means when you have been prescribed medicines, you are doing fine for 1 year, 2 year, or maybe 5 to 6 years, and later on again you started getting the symptoms, or your symptom is progressing, means you are not able to sleep in the night, or you are getting breathlessness while in the supine position, or the activity which you are able to do easily initially, now you are getting exhausted. So this is a situation we call as a remission of your heart failure, means initially you are doing well on the medicine, now again the remission phase has come, means you are not doing, and there is no intercurrent illness, means there is no precipitating cause for that heart failure. So we call as a progression of the disease, means your heart failure is now gone to the next stage. And in that scenario, if your ejection fraction is reducing, and your cardiologist will certainly evaluate you further for the precipitating cause. If the precipitating cause is not there, certainly we are having some device therapy. Device therapy means there are some special pacemakers which we suggest for that patient, and that will be decided by your cardiologist. If you really want to know what are the devices, so we call as cardiac resynchronization therapy. So when the heart is becoming weak and the pumping is getting reduced over time, LV ejection fraction is reducing, there may be a subset of patients, I'm using the word subset, there are out of 100 patients, around 30% patient is having some electrical problem, which is the reason, which is one underpinning their deterioration of the heart function, and that will be reflected best in the ECG. So if the person go and do the ECG, we get a particular type of ECG pattern we call as a left bundle branch block, means there are two bundles which innervates the lower chambers, we call as a ventricle, that is a right bundle and the left bundle. So whenever the left function, what we call normally we measure, and your heart pumping is weak, we can say that the LVEF is reduced around 30-35, and on top you are having ECG pattern of conduction problem, what we call as the left bundle branch block. Means ECG will directly show, if you see from the diagnosis, there is written left bundle branch block, or QRS, means one of the parameters, if it is more than 150, they are the ideal candidate to go for the device therapy, because in this subset of patient, which is almost 1/3 of the heart failure patients, where if you are implanting the device, the heart pumping may improve, and they can do the same activity what they have lost over the time, or due to the progression of disease, because this pacemaker is now going to resynchronize the electrical abnormality, and your functional compromise and the structural problem may reduce over time. There are situations in which the heart pumping has totally normalized after putting the device therapy. But those patients are very few, means 5 to 10% patient we call as super responders, means we have implanted the device, that special pacemaker, CRT, cardiac resynchronization therapy, and due to that the heart pumping has improved, and it is that much improved that it has almost normalized. So cardiac resynchronization therapy is one of the treatment of the heart failure patients, and if the patient is having the particular type of heart failure, means heart failure with reduced ejection fraction, on top the patient is having ECG of left bundle branch block, this type of patients are candidate for cardiac resynchronization therapy, and this you can discuss with your cardiologist, and most suitable will be the electrophysiologist who do this type of procedure in and out, and they will be having a better insight regarding the device therapy for heart failure. Coming to the second device, are called ICDs. So that is called implantable cardiac defibrillator. So when the heart is getting weak, there is chamber size are increasing, they always give they are having high propensity to develop the arrhythmias. And this type of arrhythmias, what we call as a ventricular tachycardia, ventricular fibrillation, these are the responsible, these are the killer rhythms. And when in a heart, when it is becoming weak and the patient is having any syncope, or anytime patient has collapse, the reason is mostly this type of rhythm disorder. And for that we give a therapy we call as a ICD, means these are special devices like a pacemakers. So we implant this under the skin, and the same device, means there are two wires in the heart, and whenever the rhythm disorder is happening, it will detect and it will do the same job what a doctor do. So it will capture the event and immediately take the action also. Means if the rhythm is going, which is going to stop the heart, what we call the ventricular tachycardia, ventricular fibrillation, it will shock the heart. What a doctor and nurse do in the hospital in the emergency, whenever the current problem is going, whenever this rhythm is going, they will detect and immediately give a shock. So we call as a defibrillation cardioversion, that happens when the patient is in the doctor's chamber in the hospital. But the same rhythm disorder, if it is happening in this type of patient who is having heart failure and the patient is having rhythm disorder, this device will immediately detect and do the same job what a doctor and nurse does. When it detects it will shock the patient and bring back the patient to the life. So life threatening rhythm can be detected, which happen in the patient with the heart failure with reduced ejection fraction, and in that situation it can be implanted to prevent the sudden cardiac death in the patient of heart failure. So this is a second device. Coming to the third level of device therapy, usually these are called um, left ventricular assisted devices. So these devices are a bit costlier and very high cost device. And I don't want to recommend and impress on this device, because in our country, one is the maintenance cost as well as the implantation cost. It comes around 1 crores, and really costly, and management issues also there, implantation issues also there, and the longevity is 3 to 5 years. After that, probably it may not. So it is in foreign country where the transplant can't be done. The long waiting period for the organ donation is there. There, this device is a boon for the patient. But country like India, where a lot of organ we lose because it is not reaching to the recipient, where the cardiac transplant is going to make a lot of changes. It is the attitude of the society as well as the attitude of the patient, and that is going to make a difference in the life of the person who is suffering. So coming first for the cardiac transplant, so LVAD is one of the device which is implanted under the general anesthesia. Some device being put on the inside the heart, and the motor is outside, and from that the pumping is going on. But it comes with a lot of maintenance, and it buys time for 4 to 5 years, or 6 years, 7 years, depending upon how it is doing and which generation this LVAD is. But if the person is willing for going for transplant, that is a better, because it is a destination treatment, means you can directly uh, replace the organ which is not working well. So heart transplant is the final destination treatment, and it is indicated in particular situation. It is not that any patient who is having heart failure we have to go for the transplant. When you have given the drug, and the patient or even sometimes you have given the device therapy after drug treatment, and patient is not doing fine, or the function compromise is still going, he is getting recurrent admissions in the hospital, and you are seeing that it is only and only heart which is involved, means the other organs like kidney, lungs, all are good. In that situation, transplant is the choice, or that is the choice of treatment. And as like a kidney transplant and liver transplant, heart transplant has started long back, but the perception of the people has not changed as much as it should be over the past few decades. So cardiac transplant is a well-known, established and evolved treatment of heart failure. In this, we have to replace the heart of the patient with a heart of a donor, and for that there is a long investigation loop in which the patient has to come, and later on he has to come into the Jivan Dan, means the people who are associated with the transplant. They are going to look into the feasibility and how early it can be done. So there are some routine investigation we do in the as in all the transplant. That is the routine investigation. Second comes whether he is feasible, means his heart transplant, he is really a candidate, means there are patient in which the patient heart as well as lungs or either kidney is already, or he is in some terminal illness like cancer. In that situation we say that it is better to continue on the medicine than going for the transplant. So if the patient is not is suitable for the transplant point of view, means his evaluation has been done, we do some cath study, means we take the patient in the like angiography, we check the parameters from the lungs and the heart, and after that we make an impression, yes, this patient's heart disease is only limited to the heart, it has the other organs are well functioning, and the most important organ next is lungs. If lungs pressure has not gone above the normal, so in that situation we usually we advise that patient that they should come into the loop for the heart transplant, and we then start waiting for the donors. And wherever the donors are available, particularly if the patient has been enrolled like in Kamineni hospital and patient is having waiting for the transplant, and in the same time if any accident case has come in this hospital, most of the time this is a very well positioned hospital, most of the accident whenever it happens it reaches to this hospital, and a lot of organ donation happen. If the patient's families are convinced, so then he will be the first candidate to get that organ before going to any other hospital. So Kamineni is well established center for the transplant. There are surgeons who are operating. They are well trained surgeons from the UK and US who are taking this charge. And this is the opportunity that anybody who is having they want to transplant, they have to enroll with one hospital, and with that hospital they have to pursue, and when they are being called on particular day to come for the admission for the transplant, they have to show up. That is the basic minimum needed, and before that he has to be evaluated, and later on he has been under the Jivan Dan loop, means their registration has been over. And when the transplant when the donor is ready, immediately it is done on the what you call urgent basis, that patient has to get admitted and later on transplant is completed. So this is the final destination treatment for the heart failure patient. And since we lose the organs, means the person want to donate but there is nobody available in our country or in particular center, we lose the organ, and that is not good for the humanity. From that point of view, it is very essential for as a community that we should know what transplant is and accept wherever possible, or give the favor to the patients who want and who are not convinced that whether transplant, because transplant is going to add at least 10 to 12 years. If you have passed 1 year, at least 10 to 12, you are going to add on 1 or 2 decades with the new heart, and it may be possible because the experience, the median period is around 12 to 15 years. So it may go above also, means median is of 12 years, means it may be 20-25 years you can easily go, depending upon your result and how you are doing after the transplant. So transplant is an important part of the treatment, and heart failure, this is the destination treatment, this is the final treatment, and after that it is the medicines. Hope so I have covered most of the things, and still if you are having any questions and query, I will be happy to answer.